Hello everyone, good morning. I feel more anxious over here than like sitting over there, but yeah. So first of all, the topic that I'm going to present is about the spinal neurenteric cysts. Thank you very much, first of all, to St. George University and SSF for this great opportunity for the research, and also your help in concluding this one. So, neurenteric cyst is an infrequent condition which lacks the consensus of the management approach yet. So various manifestation and different phenotypical manifestation of each cases and case series make all those medical disease very unique. This comprehensive review has a goal to review thus the general anatomy, embryology, and histology, as well as the surgical management, to appreciate the disease condition and histopathological characteristic of it. So what is neurenteric cyst? It's a rare benign cystic growth in CNS. It's also known as endodermal cyst, enterogenic cyst, or enteric cyst, or enterogenous cyst, bronchial or respiratory cyst. Why it does have so many names is because of the histopathological origin. So basically, we all know that cystic growth is an accumulation of the fluid in a cystic space, which is enclosed by a single layer of the epithelial cells. The epithelial lining of the cyst has endodermal origin. That's why it has those various names. As I move on to the presentation, I'm going to show you some of the clinical pictures so that we can appreciate some of the presentation and relate to the clinical manifestation of it. So this is one of the MRI of the patient that has been presented on the case. We can appreciate the accumulation of the cyst at this level, which is the C2 to T2, T1 vertebra. We can see the sagittal image, the accumulation over here, and it is associated with malformation of the vertebra and the hemivertebra and non-closure of the some of the spine. I'm going to discuss more in detail about those images when I hit the images section. So in terms of the anatomy, where do we find those cystic growth? Depending on the area of the growth, we can classify it as an intracranial growth or intraspinal. Intracranial one is more rare than the interspinal one. Intradural and extradural, depending on the location in relation to the dura, intramedullary or extramedullary, if it grows inside the CNS itself or outside. The ventral or ventrolateral aspect of the spinal cord is the predilection site of this benign growth. And you often find this growth at the cervical vertebra most often, followed by the thoracic vertebra and the lumbosacral vertebra. Again, the most common type of the intradural cyst is the intraspinal, intradural, but extramedullary neurenteric cyst, and that comprises about 78% to 90% of the reported cases. So the rest, 22 to 10%, is the one that we'll be finding in the intracranial area or intramedullary area, So this is another sagittal MRI, a T1 weighted image on the left side, and the right side T2 weighted image. We can appreciate the growth of the cyst that is compressing the spinal cord entirely, which flatten out the area. We can appreciate that the signaling is about the isointense as a CSF. That's kind of like tricky to find if it's small anterior to the spinal cord. In terms of the epidemiology, intraspinal occurrence is about 0.7% to 1.3% of all spinal tumors, so it's pretty rare. Reportedly, males are more affected, and the population affected is between the neonate to early 70s. So whole spectrum that could be affected. This number depends only on the reported cases. So if we take into account, if we break down on those diseases into subsets such as intrathoracic level, then this number does not really help. I mean, this prevalence does not really hold because in the case, female will be more prevalent. In terms of the clinical manifestation, again, we can have a spectrum of the manifestation depending on the location of the spinal level it will be affected. You can have pain, paresthesia, motor deficit, or progressive weakness, hyperreflexia, which is a sign of the upper motor neuron injury, urinary incontinence if it affects the autonomic nervous system, tetrachord syndrome, and if it is severe enough to compress the upper motor neuron, then you can have paraplegia to quadriplegia. So this is some of the morphology of this presentation of the neurospinal cyst. This is which is done through the posterior surgical frame. So the surgeon has opened the posterior aspect of the vertebra, and you can appreciate the dura over here, and the cyst is sitting inside the spinal cord itself, and we can appreciate the swelling. So after the inspections, surgeon have made an incision and clear fluid came out, and that is the incision site, and that's how they kind of inspected to see if it is not really adhered to the spinal cord itself to minimize the deficit of the patient. So what other associated presentation we can observe? Researchers have found two different patterns. One is the vertebral deformity, and the other one is the cutaneous anomalies. So some of the vertebral anomalies that is associated with the spinal neurenteric cyst comprises of dysraphism, malformation of the vertebra, hemivertebra, etc., etc. And also recently, they have found also some of the cutaneous malformations associated with it, but not always. It includes hair patch hirsutism, focal hirsutism, pedunculated mass, and hemangioma, as well as the subcutaneous mass. There's no clear pattern of the association between the specific vertebral or cutaneous deformity and the neurenteric cyst that's been identified, so that formula does not always hold. In terms of the etiology, so what caused the neurenteric cyst? It led us to think about and consider about the embryology of the pathogenesis. So we need to go back all the way to the third week of the gestation, where the gastrulation happened, where you have the division of the three primary embryological germ cells, endoderm, ectoderm, and mesoderm. And the failure of the migration or separation, and sometimes the defect of the formation of certain gut lining will lead to the formation of the neurenteric cyst. There are about 5 proposed mechanisms. Those include split of the notochord by the endodermal tissue or diverticulum, adhesion between the notochord and the endodermal tissue, failure of the obliteration of the neurenteric canal, incomplete escalation of the notochord, and abnormal notochord development secondary to the ectoderm or endoderm separation. What does that mean? So this is basically the axial image of the gastrulation when you have 3 germ layer formation. I got the ectoderm, mesoderm, and endoderm formation over here. I'm sorry. And my notochord is derived from some of the migration of the ectodermal tissue, which makes the future CNS system. At that level, during the formation of the notochord, my amniotic cavity and yolk sac cavity is temporarily connected through this canal, which we call neurenteric canal. Normally that canal obliterate by the end of the formation of the notochord, but sometimes they persist, and the persistence of the canal can lead to separation of the notochord, and the residual mass can form future neurenteric cysts. There are other mechanisms also which has to do with the endodermal tissue diverticulum formation from the endodermal tissue. I'm sorry, we cannot really appreciate on this screen, but this is like my thin layer of the endoderm with the diverticulum over there, and that diverticulum is adhered to the future neurotube, which makes another separation of the notochord. So those are the diagrammatic presentation of those 5 different mechanisms, and depending which mechanism will be the patient will be having, the destined manifestation is going to be either intradural intramedullary neurenteric cyst or extradural neurenteric cyst, etc., etc. So how do we diagnose neurenteric cyst? The best imaging studies, of course, is MRI, because that's how we will be visualizing the spinal cord and the cystic accumulation. But you can also employ the CT scan in order to identify if there's any associated dysraphism with the vertebra. So those are the some of the exemplar images presentations. So I got the ISO intense isointense to hyperintense accumulation inside the spinal cord, which clearly distinguished from the continuity of the spinal cord over here. But is MRI really best imaging studies and to diagnose my neurenteric cyst? Not really, because here I got another presentation of the neurenteric cyst patient that we can appreciate at the level of the C3 vertebra. But if I compare that patient to this patient who has another cystic accumulation inside the dura, inside the spinal cord, the signaling of the MRI is pretty much the same. However, for this patient and this morphology, it is a characteristic of the ependymal cyst. So with the naked eye, it's pretty hard to distinguish between neurenteric cyst to the other cystic growth in the CNS system. Therefore, we need to refer to histopathology. So neurenteric cyst has some characteristic. It has the cystic lining that has to do with the cuboidal to columnar cell, with or without cilia, and with or without mucus or goblet gland. A goblet cell, I'm sorry. And if we refer to the histology, these histology are very similar to our respiratory epithelium, to the gut lining mucosa. And the cystic content is very variant. It could be very clear. It could be containing clear fluid to the other yellow color to brown color fluid. And the molecular analysis have shown the high protein concentration and the fat concentration. So this is an exemplar presentation of the neurenteric cyst. I got the cystic space over here, which is lined by my singular or simple layer of the cuboidal to columnar epithelium, and some accumulation of the mucus gland contents over here. On the right side, I have a PAS stain, which pick up the carbohydrate accumulation that shows this positive signaling over here, therefore, which it confirms some of the endodermal origins. So if I compare my neurenteric cyst to the other cystic growth of the CNS system, such as ependymal cyst or epidermoid cyst, I can clearly distinguish some histological characteristic. If I compare it, for instance, for the epidermoid is more likely classified with stratified squamous epithelium with characterization. In the epidermis, this one does not contain any basement membrane or is not associated with any fibrous connective tissue, whereas in my neurenteric cyst is going to be associated with those characteristics. Is it really easy to identify on the light microscopy? Not really, because this is epidermal cyst, and it has also a singular or simple layer of the cuboidal to columnar epithelium, but we cannot really appreciate the connection with the basement membrane or identify the basement membrane. In that case, we need to go in further studies and do some histochemical staining. On the right-hand side, I got a fibrillary acidic protein that is staining positive, then S100 staining positive, and cytokeratin staining positive. Those are the markers of the neuroectodermal tissue. Therefore, it rules out the diagnosis of neurenteric cyst in the case that, and it more leads to the diagnosis of the ependymal cyst. Sorry. So those are some of the chemical staining, immunochemical staining that they have done on the neurenteric cyst to qualify or characterize the some of the histopathology of it. And we can appreciate that, especially over here, cytokeratin 7 and cytokeratin 20 was prevalently staining positive, which are indirect signaling of the foregut origin of those endodermal tissues. Other staining that was positive, which was significant for that one, was EMA as well as CEA, which are more prevalent in the gut mucosa. So that helped in diagnosing an neurenteric cyst, and those are the key marker that they use lately to identify those ones. In terms of the treatment, what they can do, there exist 3 treatment options. One is aspiration, the second one is fenestration, the third one, which is a more definitive one, is the surgical removal. Aspiration involves just in removing the cystic accumulation through aspiration, but solely aspiration itself does not have any treatment role in long term because the cysts end up regrowing afterwards. The fenestration involved making a shunt system between intraluminal area of the cyst to the subarachnoid space so that the compression does not occur. And the surgical removal, of course, consists of removing the entire lining of the cyst, if that's possible. So here, this patient was a little bit special because she initially had neurenteric cyst growing and compressing the cervical vertebra, which led her to have hemiplasia. And they installed a fenestration, a shunting system between the intraluminal cystic area to the subarachnoid space, but that shunt got clogged up after 20 years, so she had another surgery. So initially they went through the posterior aspect, but because they cannot go through the posterior aspect, they choose the anterior surgical plane, which was a little bit more complex because you had to go through all those anatomical structures. So this is the post-surgery picture. So conclusion. So most of the neurenteric cyst is located anterior to the spinal cord, and the proposed pathogenesis does not really clearly explain why those cysts can arise anterior to the spinal cord or the posterior to the spinal cord. And currently, there's not enough data to establish a definitive approach to the treatment. And once those cysts reoccur, they have histopathology that is exactly the same as the original masses. Thus, we can conclude that these are the recurrence of the original tumors. And that's it. Any questions?
So in the histochemistry table,
Yes.
some studies show the GFA.
Yes.
Show negative reaction.
Yes, that's true.
How do you explain that?
Oh, so here, some of the studies, so usually GFAP is staining positive for the neuroectodermal tissue, which are given rise to the ependymal cells, astrocyte, or even the lining of the choroid plexus. But there's a few, I think there was only one study whereby the GFAP was positive in neurenteric cyst, and they were saying that it could be just like focal tissue that was remaining during the growth of that cyst, which have contributed into that. But other consistent studies afterward haven't really found that positivity on the staining. Thank you. Yeah. Oh, the recurrence rate was ranging it was a spectrum because some of the case studies had like 0%. They observed it for like 6 years, but some other studies which had been observing the following up with the patient for more than 15 years, there were about 38% of the recurrence rate. So it depends also on the remaining residual tissue. If the surgeon has the chance to remove the cystic lining completely from the spinal cord, then the recurrence rate was really low. Whereas when the cystic lining or the fibrillary tissue or the glial tissue is really adhering to the spinal cord, as we have seen in our picture, in that case, because they did not want to injure, they did not want to be more aggressive because they're fearing about injuring those like neurological tissues. In that case, they choose, instead of complete rejection, subtotal rejection. In that case, yeah, the recurrence rate was higher.
Sorry, that question.
Pardon me?
I didn't get the whole thing.
Oh yeah, so the recurrence rate was related to the successful complete resection of the lining of the cyst. But whenever those lining tissue were adhering to the spinal cord really tightly, neurosurgeon did not want to excavate really tight. Yeah.
Because actually, spinal cord tissue is far more sensitive.
Exactly. Yes.
Even brain tissue.
Oh, even brain tissue.
So the spinal cord is much more sensitive. Like only a small scratch could produce significant damage to the patient. And since all these cysts are very high,
yes,
like cervical or even thoracic, sometimes what we prefer to do is only fenestrate it. It's called marsupialization.
Oh yes.
And like you mentioned in one of the cases, they put a type of
Mhm.
and that's it. Only to drain the fluid. We don't, if it's, the membrane is, as you said, very integrate with the spinal cord.
Yes.
We leave it
Yeah.
like that.
Yeah.
Because the thing is only to relieve compression of
Exactly.
the cord.
Mhm. Yeah, I forgot to mention also that because those people are suffering focal neurological deficit because of the mass effect. Once the mass effect is removed, they recovered pretty.
Therefore,
Yeah.
Great, thank you.
Thank you.